broadly speaking, when we think about patients that progress on first-line therapy, there are various mechanisms that mediate endocrine resistance, and we talked about the importance of checking for an ESR1 mutation, understanding that some of these tumors are progressing because of mutations in that ligand binding domain of the estrogen receptor, which is now targetable with 2 oral SERDs that we have approved. And then another mechanism of resistance is upregulation of other pathways that the cell is using to divide. The PIK3CA, AKT, mTOR, or so-called PAM pathway is implicated as a major mechanism of resistance to endocrine therapy. In about 40% of patients, we do see alterations in this pathway, and we do have the approval of various agents focusing on Capivasertib as the AKT inhibitor. This is a drug that's paired with fulvestrant in targeting this mutation. As far as the strategy for checking the mutation, of course, we do have the availability of liquid biopsies, which is very convenient, but sometimes there's low circulating tumor DNA fraction, and in that case, you might miss a mutation by liquid. So if certainly you don't see it on liquid, I would reflex back and check tissue. We know these mutations are stable. You can even find them in the primary tumor. These are truncal mutations. And so if there is the availability of the primary tumor and you can't get tissue for some reason on a metastatic site, that's an option as well.
Great, yes. So it sounds to me that you're testing on liquid and potentially metastatic biopsy, but if that's not available, it's okay to test on archival tissue from the primary as well.
It is.
Fantastic. Manali, I think you alluded to this, but what's interesting is that we initially had PI3 kinase inhibitor approved for PIK3CA altered breast cancer, and now we have Capivasertib or Truqap, which is an AKT inhibitor. Can you walk us through the rationale for AKT inhibition for PIK3CA altered tumors? I think this sometimes comes up for discussion, and I want to emphasize that AKT inhibition is a way to really inhibit that central node and inhibit the whole pathway. But tell us a little bit about the pathway and how AKT inhibition, like Capivasertib, is effective for PIK3CA altered tumors.
Yeah, I think you bring up a really good point that for a while we understood that PIK3 was a mechanism of resistance, but now we're understanding better what the entire pathway looks like. And so we have now the development of an AKT inhibitor that can be utilized, and we've seen efficacy in improving progression-free survival in combination with endocrine therapy in patients not only that have a PIK3 mutation, but also those that have a AKT or PTEN alteration. So it is a kind of a drug that more broadly deactivates that pathway, that entire pathway.
Great, and I think you highlighted nicely that it is a targeted inhibitor, but it's nice to have a little more broad inhibition of the whole pathway, right? Because now we can include those tumors. While PIK3CA alterations are the majority of the alterations in that pathway, we can now include AKT or PTEN alterations.